so as I say, I mean, I try not to let it undermine my credibility that the digital stuff sometimes doesn't work when I'm talking about the digital stuff and how it works. But it's... It's a meta-commentary. Let's see. It was wonderful and protracted. Oh, wait, I don't mind. We're based in Somkele, which is near Mtubatuba, northern KwaZulu-Natal, and we have a site which is in the medical school in Durban, so it's in Umbilo Road. I think we pride ourselves on being an institute that does kind of the full value chain from basic and translational science all the way through to kind of clinical intervention, clinical trials unit, which is new and very shiny. Ooh, and I'm going to be nearly off the hook for giving us full pitch about where I work. Can everyone see these clearly? They seem to be a little bit faded from my perspective, but I'm not sure if that's...
It's improving, actually. It's kind of like... It's coming
strengthening as I speak.
Yeah. It's actually good now. It's fine.
Okay.
Yeah.
Excellent. Cool. Now I can tell you why I'm really excited to give this talk. So I love speaking about digital mental health interventions for a variety of different reasons, but I think one of them is that it's a topic that makes people lean forward. So in a past life, I was a journalist, and editors always used to say to you that your front page story needs to be the thing that makes someone go from reading the paper like this to kind of leaning forward. And that kind of, oh my goodness, yes. Oh, I have two. Look at it.
Thank you.
Thank you very much. The reason I think that digital mental health interventions evoke that reaction in people is that many of us who come from kind of clinical training in mental health really fundamentally value the human, right? So we were trained in modalities, but often we were meant to think about what the person and the kind of interpersonal and those dynamics mean in the context of mental health intervention. But then those of us who work in public mental health are constantly confronted with issues of scale, of implementation gaps, of lack of access to resources. And so digital tech, which is kind of, as I'll get into, heralded as an opportunity to bridge some of those gaps, I think evokes both a lot of optimism, but also I think a certain amount of anxiety. And it's quite interesting to sort of sit with that and think about what it means for the field and how we think about digital mental health, particularly in under-resourced settings. So where I'm going to go today, I think maps broadly, and this is the nice thing about doing a talk like this, is that I can just tell you what I think. But this maps roughly my thinking about digital mental health. So the first is just to recap why there is so much excitement. So why do people want to invest in digital mental health solutions, and why they're particularly excited about scaling those solutions to young people, and particularly excited about doing so on the African continent. Then I want to look a little bit at some promising examples. So there are many, many, many. In fact, I think at latest count, one of these sort of digital navigators that mines apps from the internet and tries to evaluate them, there are tens of thousands on the App Store. So there are many examples of digital interventions. I want to call out 4, which I think hold particular promise for bridging some of the gaps that we need bridged. And then I'm going to kind of bring us crashing down a little bit. And that's because they are very real pitfalls. So the talk, the promise, we're going to talk about the happy stuff, and then we are going to have to try and grapple before we get to the kind of the horizons and what's next with some of the issues that are inherent in thinking about digital interventions for mental health, particularly with young people. So one thing I want you to bear in mind when I say digital mental health interventions, for the purposes of the talk, it's easy to kind of use that catch-all, but it is a very broad spectrum of different interventions. So from the kind of mauve, we have things that are technology-enabled or technology-facilitated. They're not inherently techie. A good example would be doing online therapy. We like to believe that the active ingredients are still the same, that the way therapy happens is still very similar. So it is an offline process that has just been put online. Similarly, if you kind of move along, we have things like screening. So you take a screening instrument like the PHQ-9 and you pop it on a tablet, and suddenly it is a digital mental health thing, But technically, it's still a screening tool. It's just been put on a tech platform. And that has benefits for cost, it has benefits for implementation, but it's not inherently sort of a techie thing. Then we move along, and you increasingly see the role of technology kind of coming front and center to the functionality of some of these apps. So in the middle, somewhat in the middle, that very sort of purple and green tiled thing is from Moodflow. Moodflow is a mood monitoring app, and every day it'll ask you to sort of check in and say, how are you doing? And you can say, okay, well, today I'm feeling a little bit, like a 5 out of 10. It'll say, did you sleep well? No. Did you drink water? No. Did you run? No. Over time, it'll build that sort of tile to tell you when you had good days and when you had bad days. Now, that's something you could do on your own in your diary. But what Moodflow does, using that kind of techie back end, is that it begins to say, oh, on days that you sleep well, your mood is higher. It's a better rating. On days that you drank water and ran, we can see that you have a better kind of pattern in your mood profile for the following days. So it's beginning to make some insights. And then you move all the way to kind of gamified CBT, which I'll speak a little bit about later. Then you have these, the very cutely named Wobot, which is a chatbot for depression. And this is very much kind of drawing on core tech functions, so kind of natural language processing, and then things like wearables. So these are now kind of classified as digital therapeutics. So things where the tech is inherently adding kind of therapeutic value, we think. And some of the really interesting wearable research has been in countries like India, etc., where they've shown that just by looking at sort of digital biomarkers, so how much you sleep, what your heart rate is doing, where you're moving, you can do things like predict first episode psychosis. It's very interesting. So there's a lot of potential, but I think when we get into the implementation stuff, we need to think about what that looks like in our setting. So bear in mind the continuum. Now, the first kind of pillar in the argument for why people get really excited about digital mental health interventions on the continent is mostly to do with youth. So why do young people need mental health interventions at scale? So we know about 63 to 75% of all mental health conditions have their onset before the age of 25. It's the exact epidemiological inverse of physical illness. So with mental health problems, you get ill when you're young. With physical health problems, you get ill when you're old, right? Mostly. But what we also know, and this is really, really kind of a huge gratitude to Dan Stein and his group, to produce a very good meta-analysis with an incredibly large number of kind of pooled adolescents in the sample, and showed that in sub-Saharan Africa, and it is a limitation and it's kind of a call to people in this group, the sub-Saharan distinction sometimes limits what we look at, but in sub-Saharan Africa, we know that we have incredibly high prevalences amongst young people, kind of 10 to 24, 15 to 30, depending on the study, of depression, of anxiety, PTSD, etc. These are not mutually exclusive, but they are very high rates. Another reason why we need to think about scaling these interventions is that we know that on the African continent, as globally, young people are facing increasing complexity, right? So we have urbanization, climate change, and other kind of mega trends that are fundamentally shifting the landscape that they're entering into. So adolescence is a time of difficulty and turmoil at the best of times, and now people are trying to do it when there's massive migration. They're trying to emerge as a kind of 24-year-old with a good ability to function socially and the prospects of livelihoods when jobs are changing kind of by the day and the nature of the world of work is changing. And we also know that kind of unique to the continent, we have incredibly high rates of poverty, of violence, of food insecurity, and that these cluster. So if you look then at our kind of population profile, it gets into why young people specifically. So we know that they have mental health problems. Why young people in Africa? We have an incredibly large youth population. This is fading a tiny bit. Are you still hearing me? Yes. Okay, cool. So by the year 2030, it's projected that about 42% of the world's youth will live in Africa, which is an incredibly large proportion. So if you look at other regions, you can see that kind of the age profile is shifting. Even in Asia, it's kind of tampering down. But in Africa, we have a very large youth population. And this is UN Habitat's language, not my own, but slum is a very particular type of dwelling profile that they map, and so this is the map that you generate if you look at a type of urbanicity. But people living in informal urban environments are very heavily concentrated in Africa. So we have a very high need, we have population who are young, who have mental health problems, who are facing these kind of complex environments, and yet we have very few services. I'm not going to belabor this point. I'm sure it's been made before, potentially yesterday, but it might also be something that you're all familiar with. If you look at countries like Norway, the ratio of psychiatrists to 100,000 people in the population is about 48. In Chad, it is 0.01. So there are massive, massive gaps, and that's just one example. So psychiatrists are just one category of healthcare worker who can deliver mental health interventions. It's not to mention kind of physical infrastructure, etc. So there are these gaps in access. And the final kind of point and argument that people might sometimes make about why Africa, why now, why young people, is that these infrastructural constraints, the lack of human resources, the lack of kind of built environments to meet challenges, has historically been met in very creative ways in Africa. A very good example is here in Kenya with M-Pesa. So in 2018, M-Pesa had 25% of the global mobile money market. It's a massive, massive share. And M-Pesa, which is digital banking, for those of you who don't know, sort of phone to phone, managed to leapfrog. There was no need to have tons of physical banking infrastructure, tons of ATMs, and all of the human resources associated with it. It was at a time when tech was booming, and entrepreneurs capitalized on that. And they were able to leapfrog the country to a point where the tech innovation could meet the need in a very innovative way without going through all of the previous kind of investments. And we've seen this with information and communications technologies elsewhere in Africa, where countries were at a kind of ready point to invest in ICT at a time where cell phone towers were already the thing. So you didn't need to do the pole and the landline and the things that we all have and we see around cities. You could leapfrog immediately to a point of innovation. And I think that that is one of the really exciting things about meeting the challenge and the kind of gap in mental health programming in Africa, is to try and harness some of this technological creativity. So therein lies the promise. The promise of digital mental health interventions that is often heralded and that is spoken about, and that we think about when we want to innovate, is that they can meet implementation challenges, they can scale solutions, and importantly, they are increasingly able to be adaptive in real time. So, four that I'd like to call out, because I think that they have the greatest applicability to the African context and the greatest applicability to young people, are screening, so sort of digitally enabled screening, health systems integration of digital mental health interventions, suicide prevention and intervention, and then CBT, so computerized CBT. The first one I think is one of the less contentious applications of digital mental health, which is screening at scale. Where it becomes contentious is when you think about screening at scale and what that implies for your brick and mortar services, but we know that it works. So if you take a screening tool that you would usually kind of self-report and you pop it on a tablet, no big surprises there, it kind of works, it can be quite useful. However, you are then able to screen people at an unprecedented scale. So when you might previously not have known everyone is really depressed and in need of therapy, you now know everyone is really depressed and in need of therapy, which is unhelpful if you have 0.01 psychiatrists per 100,000. So there's this adage of you don't screen if you can't intervene. And now we can screen at enormous scale. But there are really interesting opportunities, and one of them is also in doing observational measurements at scale. So this isn't just about putting the PHQ-9 or the GAD-7 on a tablet or sending it out to people. It's also being able to directly observe. So for instance, I used to do early childhood development research, and with little kids, you would have a tablet with a front-facing camera. And when they're watching a little video of a bunny, and I've watched this video 1,000 times, standing behind kids, it's a little bunny, and it hops around, and it's a very annoying song, but it's a novel stimulus. And the kid is plonked in front of the tablet, and they watch the bunny. And while they're watching the bunny, the front-facing camera comes on, and it tracks their eye movements. So it's a very good objective measure of attentional control. Now, there are lots of issues around whether they've seen a tablet before or a bunny before, etc. But it can scale, and it might be easier to scale than other measures of attention in small children. So there is a lot of promise here. Where I think it also gets a little bit complicated is that many of these kind of screening measures or direct assessments are now available direct to users. So if any of you were to open your phone now or at any point during the day, you could take the GAD, you could take the PHQ-9, you could probably do an attentional assessment on yourself, you could download an app that will tell you what your personality is like. And while that is really useful information to have potentially, there's no follow-up. So normally, if you were to, for instance, be in a clinical interview and be screened and you do the PHQ-9 and you say, I'm a bit suicidal, ideally, someone is going to follow up with you. They're going to unpack that with you. Maybe they will call you the next day to see if you went for the follow-up services. With a direct-to-teenager app, they might be disclosing that information in an environment which feels inherently therapeutic and safe, but is an app. And so it's quite interesting to think about what it means to enable assessment amongst users at a very large scale with very little ability to follow it up with services. The next thing that I want to talk about is health system strengthening, also not kind of wildly contentious, but very useful. So we have very good examples from HIV and NCDs and TB research of how you can use prompts, so very simple things like little text messages or facilitated WhatsApp groups to remind people to go to the clinic or to support them to go to their local community health worker. We also know that you now can kind of scaffold clinical interactions or somewhat clinical interactions for lay cadres of healthcare workers. So for instance, with things like kind of motivational interviewing or behavior activation, you can scaffold an interaction for someone who hasn't had as much training, and you can deliver supervision through an app. So there's immense potential. I know that there are also people in the room who work in this very space. There's a lot of potential to strengthen core parts of healthcare systems in a way that allows a lot of control and a lot of support and is potentially very cost effective. But one example for young people that I think is particularly interesting, and we are seeing some of these emerge in Africa, but I'm going to use an American example because it's kind of the best known. It's called Teens in NYC, which is unsurprisingly delivered to teenagers in New York. And it had 3 functions. So essentially, administrators working in sexual and reproductive health for adolescents in New York realized that young people were quite savvy and they sort of wanted to get services. They kind of knew which services they wanted, but they didn't know exactly when and where. So you would have potentially a pregnant adolescent seeking sexual and reproductive health care services at a OB that was not kind of a youth-friendly healthcare clinic. Or you might have young people wanting to know what are their options for contraception that are maybe they don't have to disclose to their partner, but not knowing where it was safe or appropriate to have that conversation. And so it had these 3 different categories. The first is where to go. And it essentially supported young people to navigate the geography directly around them. So it's to say, where you are, these are the healthcare facilities that have teen-friendly sexual and reproductive healthcare services. You can imagine in South Africa, as an example, where we know that we have roving mental health teams. So they move. So on Monday they're at this clinic, and on Tuesday they're at this clinic, and on Wednesday they're at this clinic. So if you're a young person and you're wanting to access services, it's very useful information to have. Don't go on Monday. They're not there on Monday. They're there on Wednesday. Go on Wednesday. The next thing is what to get. And the what to get is really psychoeducation. So in this context, it was information about different types of contraception, about different categories of healthcare worker. So who is a nurse? How can you spot a youth-friendly SRH service? But for us, it could very much be information about common mental health conditions, about different categories of healthcare worker that could deliver mental health interventions. And the last bit, which I think is really interesting for mental health, is what to expect. And the what to expect tab had little videos of successfully completed interactions between young people and healthcare providers. So what can you expect when you go and see a nurse and you want to get the pill? What can you expect when you go and see a nurse and you want to learn more about different options for contraception? Because expectation is so important to the success of mental health treatments. We know from doing digital studies in South Africa that if you have an adolescent and they want one-on-one therapy and you refer them to a low-intensity condition like an app, they will be disappointed in that app. They may not expect it to work and they won't use it. So having these opportunities of short videos, scaffolding, setting expectations, saying this is what the app will do, there's evidence that apps work. This is how the app works. This is what a therapist would do. This is who might want to see a therapist. Those kinds of examples can really support and kind of bridge some of those gaps between what young people might think they need and the different intensities of therapeutic options available. The next one is suicide prevention and intervention. And when I get to the come crashing down part, I will speak a little bit about iatrogenic effects, and I will speak specifically about a direct-to-user suicide prevention intervention. For now, the example I'd like to call on is probably most useful for the researchers in the room and for those of us who are kind of thinking about monitoring. Coco is a barrier reduction chatbot. So you know when you kind of want to contact your bank or your airline, etc., and you have a very scripted chatbot. So it's not a natural language processing algorithm that's doing all kinds of fancy things and learning on its own, but it is offering solutions. And sometimes, like if you want to change your PIN on your card or do something relatively basic, it's helpful, right? Coco does that, but after a suicide flag in a questionnaire. So when you do research and you include, for instance, a measure that has suicidality or suicidal thoughts and behavior, one of the things that helps you sleep at night as a researcher and contains your ethics committee is knowing that there's a plan in place should someone say that they are experiencing suicidal thoughts and behaviors. However, in a lot of survey research, we know that it's not resourced well enough necessarily to have a project manager phone every single person the day after and say, did you go? That little pop-up comes up and it says, you are experiencing significant distress, we think you would benefit from X, Y, and Z. But there isn't necessarily budget or ability or time to follow up every single person. And you should, and we say we do, and in well-resourced trials we try to, but it is very labor-intensive and it increases cost, and it's also very easy to start missing people. So what Coco does is as soon as that little flag comes up that says we think you should get services, and here's the number, dial this number, immediately Coco comes up, and in quite a human-like tone, so I'm going to imitate it, but it's a robot. Sort of says, hi, do you mind being honest with me for a second? How likely are you on a scale of 1 to 10 to call the number we just asked you to call? And adolescents, unsurprisingly, will say 3. Not gonna. And it says, thank you so much for telling me. Again, in quite a human-like chatty tone. Do you mind showing me from this menu why not? And a little menu pops up, and it's things like, I don't really think I'm depressed. I pressed the wrong button. I'm not actually suicidal. It's too expensive. I don't think therapy works. I don't want to meet someone face to face. It's stigmatizing to go to the clinic. And based on that answer, it suggests scripted solutions. So it reduces barriers to care, which we know young people feel particularly acutely. So if a young person, I'm back. If a young person says, for instance, I'm scared of stigma, it might say, okay, but here's an online service near you. Please follow up. Now, you would still need to have a case manager follow that, but it really increases the probability in studies that it's been implemented in of people following up and actually accessing care after disclosing suicidal thoughts and behaviors. And the last example is CCBT. So myself and a colleague called Jason Bunches and others have done some research evaluating these amongst university students in South Africa. What's really interesting is that these computerized CBTs had kind of evolved over time. They started out where it was just very scripted CBT on an app. They then became slightly more gamified. So these are screenshots here from Super Beta. And you can see you can battle bad guys. It was quite interesting. At first I was worried that amongst kind of 18 to 21-year-olds that they might find the gamification didn't sit well with them. And yet they did, and they liked it, and they played it. They might not have told their friends they did, but they did. And it turned out to be just about as effective as online group therapy. So it's really interesting. Now, what's also interesting is that many of these apps now have guided and unguided versions. So Silver Cloud, which is similar, also sort of gamified CBT, has a version where you can buy a percentage time of a therapist who then guides the person to use the app, who checks in as a live kind of warm body within the context of the app. And I think the kind of research horizons now that I'll speak about at the end of the talk is trying to understand who needs what. So who needs the warm body in the app, who is okay with just the app, and who might benefit from something else entirely. So those are our sort of promising things. And then the pitfalls. So I always feel like it's a little bit dramatic to call them pitfalls, because the first part are really sort of bad things that you don't want to happen, that would keep researchers and interventionists up at night alike. But the latter part are really just implementation challenges, or things that we need to think about carefully. So I'm going to start with the kind of really pointy end, and then I'll move into some of the moving target. So iatrogenic effects. If you look here at the dark blue line, that is suicidal hospitalizations for suicide attempts and completed suicides amongst people who, in a trial of about 19,000 Americans, were more suicidal and received a digital dialectical behavior therapy intervention. So if you look at the different lines, usual care, that's time to an event. So, you know, a serious adverse event. In this instance, they looked at completed suicides from the mortuary, and they looked at hospitalizations. Orange line is kind of care management, which is sort of enhanced care. And then these, the people who became more suicidal and who were more frequently dead or hospitalized, got a little app that delivered DBT for their suicidal thoughts and behavior. So this is the really kind of sharp end of things, is that iatrogenic effects happen, things go wrong, but they can go wrong at a massive, massive scale. And now, obviously, we have the DSMB in the context of this study. As soon as they picked up this kind of differential effect, halted the study. But because it had reached so many people already, a lot of harm was already done. Similarly, the National Eating Disorders Association in America developed a supposedly rule-based chatbot for people living with eating disorders. It went off script and went and trained itself on the responses from people with eating disorders, and then began to give advice that was pro-disordered eating. So it was turned off, and they tried to figure out why that had happened. But these things happen, and again, it happened at a massive scale because it was NIDA's kind of flagship. It's an interesting thing. It's potentially useful kind of use case. But it learned from responses, and it started giving suggestions about dieting and exercise. It's unhelpful. Now, again, I think the main thing here is just the importance of piloting and testing at a small scale before scaling. But it is a really kind of sobering thing to think about, that sometimes in our enthusiasm for these solutions, we scale them potentially too quickly. The next is a slightly softer issue, and it's really to do, and I'm glad that there was someone yesterday who spoke about big data. And big data is incredibly important, but there are disparities in access to digital technologies. So the people we're harnessing the big data from are not all of the people. The bigger issue in the context of kind of interventions is that the digital inequalities, so the people who do not have access to phones, are precisely the people who we say we're going to meet the gaps in respect of. So we're going to use digital mental health to reach underserved populations, including women and rural people. And yet precisely people who do not have digital technologies, women and people living in rural areas. So if you have a look, these are gender gaps in ICT in Africa. So purple are girls and blue are boys. And then this is just from one study that was done in Somkele, near where I am. If you look at the red box, which might not be very clear, you can see that many people, about half the sample, had heard about mental health apps. Absolutely none of them had used a mental health app. And that's got to do with Wi-Fi connectivity. It's got to use with apps not having offline functionality, and just having kind of no scaffolding to where to access them and where to kind of use them and how to use them. And the last one, which is slightly funny if you put a wry lens on it, but not very funny if you're trying to do it, is that making tech speak to other tech is very, very difficult. And so integrating these different technologies within health management information systems is really hard. There are also important ethical questions about, for instance, if you want to use digital data, so your health insurer might have your smartwatch data, they might know how much you're walking, and they might be really proud of you if you walk a lot and you get a little badge. In South Africa, they do that a lot, so it's kind of gamified health behaviors. How much of that information should they be giving the health system? So for young people, screen time. Should the information on how much screen time a young person is having, is that an indicator that needs to be fed into the EMIS, so the Education Management Information System, or is it not? How do you decide? So we're increasingly collecting data on people and thinking about how we can integrate it with our kind of core indicators, but the rules about which and how and privacy are incredibly complicated. We also know that historically in Africa, our systems have been blown apart by parallel infrastructure development. So if you look at Mozambique, for instance, as an example, in Mozambique, in response to kind of child undernutrition, you had lots and lots and lots and lots and lots of programming on child undernutrition. You have lots of different cadres of community health workers all trained on a different program on child undernutrition. And that met a need. However, when you then reach a kind of another level of development, you want to bring it all together and say, what is our indicator? What is our package for child undernutrition? It's very complicated. And there's a risk with these digital technologies that if you don't build them into the system at the beginning, they are going to proliferate and then be very hard to build into the system later on. Okay. So how can we strengthen all of this? I'm going to end on a few of these ideas for kind of the key things that need strengthening, and then the horizon. So kind of what are clear things that we know we need to change, and then what does the future look like? So what are the next steps? One of the big answers here is in precision. So when I spoke about the kind of guided versus unguided version of an app, we know that there might be categories of young people for whom the unguided version is preferable. They do not want the person. The whole reason they want the app delivering the CBT is that they don't want the person. It was really interesting after COVID implementing online therapy in South Africa with university students. The ones who had liked online therapy before COVID because it wasn't in person were the ones who, in online therapy after COVID, didn't want their cameras on. So the social anxiety had kind of scaled, right? So they might be people who would really like to just have an app that gives them what they need, that supports them, but is entirely contained in an app. But we don't know. So precision approaches entail gathering tons and tons and tons of data, like the speaker yesterday spoke about, and then being able to say what works for whom. But we need to be really, really wary of the fact that those precision approaches won't tell us about marginalized populations until we have data on marginalized populations. So we know that, for instance, in AI, there's a lot of racial bias because they were not trained on diverse data sets. So you have a risk of learning what types of interventions work for what types of people, but those people are not then the people who those interventions are being delivered to at the end of the day. So big data in the context of really diverse samples is kind of one of the next frontiers, in my opinion. Next one is really interesting, I think quite sweet and encouraging as a parent of a little kid, is that adolescents really like it when there's a human in their app when they're younger. It's quite sweet. There was a lot of research done on a parenting intervention by Lucy Kluwer. So Lucy Kluwer, many of you may know, has done incredible work around nonviolent parenting. And they had a package which worked. It supported parents of adolescents to be nonviolent in their discipline. They then thought, okay, well, this works. It's amazing. Pop it on an app. Put it on an app. The uptake was not particularly high. They then got a facilitated WhatsApp group. Once a week, parents join the WhatsApp group, someone chats to them, they go to the app. And the uptake went to about, I think the adherence was about 90-something%. People use it very regularly, and they use the WhatsApp group to talk. So parents and adolescents alike kind of need the human, and they need that facilitation. Again, there might be differences later on in who needs how much, but it is a kind of thing to think about. And in the context of an app, which feels fundamentally very private, it's on your phone, how do you still bring in caregivers and trusted adults? We know that having one trusted adult in your life increases your odds of success and thriving. How do we involve that one trusted adult in this very techie space that they may not feel kind of well-equipped to participate in? And the last one, I think, is kind of a learning from the social protection research. Not all solutions to psychological problems are psychological solutions. So we do lots and lots and lots of psychosocial programming, but there is research on cash transfers, on cash plus care, etc., which suggests that many of these are very well situated within a suite of other things. So with social protection programs like unconditional cash transfers, for instance, for pregnant women, for pregnant young women and adolescents, we know that when that cash transfer is kind of coupled with other things, so you get free transport to school, you get access to a stipend to buy books, and you get access to, for instance, therapeutic services, etc., that's more likely to work. So using those models, I would encourage us as a field to think about how can we embed these, knowing that these digital technologies that exist on a phone are operating in the context of very complicated forces that are very real. Hunger and poverty and violence, how can we embed them in such a way that they are part of a suite of care? And then the next part, and the final part, is really the where to from here. And this is, I hope, a point that we can take into the conversation, because these are not answers, these are suggestions. And these are things that I find interesting and that I think we are seeing a kind of increase in investment in. The first one is digital navigators. So in one of our colleagues at Harvard now runs this, John Torres, and it has taken the enormous number of digital mental health apps that are on the iStore and on Google Play Store, and it has evaluated them. It was originally done by clinicians who would assign a weight and kind of say, okay, it's got some evidence behind it. There's one published RCT, so it gets a point for evidence. It has, this type of characteristic and this type of characteristic, etc. Now it's done by crowdsourcing information. So as you go onto the platform now, later I'd encourage some of you to go on and have a look at it. It will then ask you to participate in some of the kind of user feedback. What it means now is that you can go on here and it helps you navigate the digital resources. So you can sort of say, okay, well, I want help with anxiety. I am a woman. I would prefer one that has been tested in an LMIC. I'd prefer one that's been tested with women. And I would like it available in Spanish. Click, and it'll pop up the answer if the answer exists. It's a really useful resource, I think, particularly for young people, to help kind of navigate this very complex, very appy space. Next one is to think about investment. So this is an example of, in the United States, all of digital health. So this is not just digital mental health, but it's a useful graph because it shows a massive uptick in investment. That is 21 odd billion, or 21 odd billion dollars investment in up until the first quarter of 2021. So Q1 through Q3 of 2021. If you look at investment, and this is just digital mental health in South Africa, you can see it's projected to reach about $500 million by 2030. And then you look at the funding gap in scaling community health worker programs. That's just in Sub-Saharan Africa. So if we're going to be making massive investments in digital health, but we still have massive investment gaps, how do we make those things work together? Is it about thinking, and I don't have the answer, and thankfully there's some people who work in the funding landscape in the room who can help think through this, but is it about kind of funding things in synchrony? Is it about thinking of them as not in competition with one another, and that there's kind of core infrastructure funding versus innovation funding? But it's really trying to think carefully about, if we are going to invest, are we directing investment away from services that we might need, the 0.01 psychiatrists, or are we not? And are these kind of different spaces? And the second last thing that I want to just mention is this idea of localization versus scale. So scale is like the holy grail of public health, mostly, right? It's this thing that we chase, that we want to do. We always have to speak about how we want to scale, how we want to scale up, how we want to bridge gaps and innovate at a large scale. What that sometimes means for tech is that we devise these interventions that essentially are kind of like a skeleton or scaffolding that can be gutted and adapted for a context, and gutted and adapted for a context. Versus, if you look at place-based approaches to health, or hyper-local approaches, which we're all very familiar with. I'm sure many of you have been to a farmer's market or something like that, been encouraged to shop local, buy local, think local, right? The glocal. What is the place of the local in this global landscape? How do we weigh those two things up? Why are we designing something generic and then endlessly adapting it? Is it because of the active ingredients? That would be a happy answer for me. I think I'd be satisfied with that. If it's that we know the active ingredients work, it just needs a bit of adaptation. But I don't know that that's always the case. And so thinking about this kind of hyper-local approaches, the importance of lived experience, the importance of culture and context to meeting young people's needs, versus these very big products that don't have a lot of specificity to context, but are very consistent across a variety of different contexts. And how do we think about that and in the context of what we do? And the final one is really about involving young people. It is incredible when you have a look. There was a recent systematic review which looked at youth co-production in the context of digital mental health interventions. As a field, researchers are making a lot of progress. The first studies that were published, adolescents were, I think they called them ideators or co-ideators. So they sort of would share an idea, and then the developers would run with it, and the researchers would run with it. And then there were sort of more co-creators, in that they would have a little bit of say about how the app felt and the platform. And now kind of on the entire value chain, from thinking about the app that is needed or the other technological innovation that is needed, so how to make it really appropriate and useful and speak to young people, all the way to thinking about its implementation and its evaluation, is involving young people, if possible young people with lived experience, along every single step of the way. Because it is remarkable the kinds of insights that they will share about what works versus what doesn't work and why. So thank you all very much for your time.